So I wonder, can we just go through just to introduce ourselves? Can we start with Sharif?
Oh, you're gonna start with me, great.
Please. Everybody knows up on this side.
So I was just saying, I'm gonna be really honest. I'm Sharif, I'm a peer lived experience practitioner. This is a little bit different for me because I was saying to some of the people I spoke to before. So I'm a security guard by background. So I used to walk here and make sure that this is safe. So this is the panic attack that I'm having right now because there's a lot of attachment to it for me. But I'm really glad to be here. I'm a peer support worker. Please don't be worried about me sweating. That's my attack. But I'm really glad to be here. So is that okay as an introduction?
Yeah. Thank you.
Yeah. So that's okay. I'll speak into the mic because I've just got a little voice. So I'm Tamar and I work with the LUG. So I'm sure everyone's heard of the Lived Experience Working Group with the Mental Health Policy Research Unit. There's lots of acronyms, aren't there? Yeah. I'm also work as a freelance lived experience practitioner. I'm sure you've heard of those. And also, what else? Work for the NIHR, do all sorts, wear all sorts of hats. So that's me.
Hi, hello, I'm Julie Wepper. I'm director of IMROC. Background, before I went into nursing as somebody who used services, what is my background? I've been a nurse, an educator, a manager, and probably most relevant here is that IMROC kind of developed the first peer support training in England, co-produced it, co-delivered it, and now, alongside with you, we provide a lot of the training for peer support workers.
That's right. Hi, can you hear me? Hi, I think we met earlier. I'm Danny. I'm a equity consultant for IMROC, but I'm also a peer support worker and advocate for CAPSA.
Hi, we also met earlier. My name is Gabrielle Duberry. I am the service manager for CAPSA at the moment. I worked as a peer advocate for CAPSA, and yeah, so I've worked, you know, my background, I've done working with the NHS and working in different services. So that's me.
Thank you. To kick off, we've got some prepared questions, but if you guys want to think of some questions as well, we're going to make sure everyone is quick to time on our questions, and then we'll open it up to the rest of the room. And if anyone online has any questions as well. And we have the wonderful Karen as roving mic, so she's not left out at all. So if I could start first with Danny and Gabrielle. So peer support is rooted in lived experience and activism and advocacy, as you kind of talked about. So why do you think that those are closely related, and why is that so important?
Okay, I'll take this. So one of the main important things is that for us, we can see that, you know, it's activism, I can't even speak today, sorry, but activism is kind of looking at not just the issues that are, it's looking at the issues that are surrounding the service users that we're working with. And sometimes that means you have to challenge the kind of the consultants, challenge the nurses, challenge the clinicians involved. So that in itself is advocacy. Advocacy doesn't have to necessarily be under the, you know, the IMHRs, like, and it's just something that we are able to provide also. So the independent mental health advocates do more of a, I suppose, a statutory kind of role. And what we're doing is looking at the service users and what they think are important and advocating for their voice. Would you like to?
Yeah, I was just going to add that I think that it's something that we're continuously seeing is that I think earlier someone spoke about the role ambiguity that goes on within peer support. Yeah. And I think that sometimes it's important to, you know, almost take advantage of that and use that as an opportunity to kind of advocate based on the needs of an individual and kind of work from the needs of the individual. So when we're talking about kind of peer support, sometimes that might lead to kind of advocacy-based things when you enter someone's ward round, for example. because of the needs that are presented within the moment. So it's an important kind of area in which that we're trying to kind of establish the fact that peer support kind of involves advocacy, and advocacy also involves peer support, I think is an important one to kind of remember when kind of working with the rights of someone and acknowledging that someone might not understand what's going on within their care. It's important that their emotions are supported within those moments. And then we're not just talking about sections of the mental health law.
Fantastic. Do you want to?
Yeah, sorry, I just wanted to say one more thing. So one of the things that we're also using as one of the ways that we're actually able to provide this advocacy and peer support is through sort of the activities that you kind of saw. One of the activities was football, and we also do, like, we've done music appreciation and just kind of sitting down and speaking to people. And not only does that kind of has the activity involved, but conversations are kind of when you're speaking, it's the issues that are kind of coming out, and we're able to provide that peer support and that kind of information that we're able to provide our own lived experience. But not only that, if there is kind of issues that need the advocacy, we can provide that also in, you know, speaking on a real level, kind of what we kind of can see can be the issues, and we can kind of speak to the nurses and say, well, actually, that's not right, because this is affecting this person in these different ways. And maybe if we did it this way, it might change the outcomes for that person.
Yeah, I think I'm just kind of honing in on the same point that basically we've with music appreciation, but it's probably the best example, because we've been able to kind of use music as a sort of Trojan horse in order to kind of get real conversations going about things that people are finding challenging and things that people might not want to advocate for themselves on. And with that, you know, we have the opportunity to support them in a peer-led way, but also kind of allow them to, you know about what's happening with their own kind of care, and be able to champion their own voices a bit more. Yeah.
I think that's really interesting, because I've just started a piece of work with the team about activities and how that has so much more than just boredom. It's so much more, and the role of peer workers being kind of part of that is really, really important. So I love that we're doing that.
Absolutely. I think that it's, you know, it's easy when you work in traditional medical models to kind of trivialize activities as just something to pass time. But, you know, when you really consider what they do for people in rebuilding people's lives and allowing them to socially engage with others on wards, it can break down some of the issues that they've been facing outside of wards and in inpatient facilities as well.
I mean, even if you look at the kind of medical model at that point, even something as simple as, you know, the football, it kind of helps them with their physical health as well. And that's something that is kind of missed out on when people are looking at mental health. And it's so important because the two are such, you know, interlinked things.
I think from what you guys have talked about, it links really well to the question we have for Tamar, and really about that kind of mad activism and the work that you've been doing in that area, and kind of the importance of lived experience being in the center of that work. So I wonder, could you kind of give us a bit more information about that? Because I think it links.
Yeah, I think it's quite interesting how MAD's activism links with the what you could call the professionalisation of lived experience working. And obviously originally lived experience working came from the MAD community, and it's something that has, or a lot of MAD activists would argue, has been appropriated now, and that people who are trained as lived experience workers actually don't have the links anymore with the MAD community. And part of that is because organisations that get the funding aren't lived experience led organisations, and also the organisations that do get the funding actually don't provide the education and the educate people on the roots of where the activism of where lived experience working comes from. Part of the issues with this is that at the one of the and the lived experience working group, one of the issues we find is that the knowledge is within grey literature, and it's also oral knowledge. So the way that knowledge is encoded is not a way that organisations would generally access MAD knowledge, and also organisations do not have the same links with the MAD community. And also there's something about power as well when we're talking about co-production, and the fact that why don't organisations partner? I'm going to say partner with lived experience organisations, thinking about lived experience led organisations. So you're thinking about not organisations such as, for instance, like a Mind charity, where you do have people with lived experience working within the organisation, but you don't have people set up who run it, who actually are working in roles that where they work from an experiential lens, or have links with activists, or where their roles actually require them to have lived experience and also work from the point of that lived experience. And it makes a huge difference. And one of the examples of this that we have within the literature is we do have our own professors, we have our own doctors, we do have academics that write and are activists too. And we had Professor Peter Beresford, Dr. Diana Rose, and Dr. Sarah Carr. Professor, what's her name? Diana Rose. And they actually wrote about how millions, it might have been billions, are actually spent on public and patient involvement work when it comes to sort of research funding. And not one penny of that was actually given, not any of that funding was given to lived experience led organisations or researchers. It was given to organisations who then partnered with organisations. When I say partnered, they didn't really partner, they just sort of gave some of that money. So this is where the issues are when it comes to the power, and when it comes to actually the links, the roots. You know, people, there's a literal blood, sweat and tears that have, you know, gone into this. And we've, the people who reap the benefits and who reap the power, they reap the money, the, you know, the funding, are not the people who have put the effort in at the beginning. Happens with all forms of oppression.
Thank you, Tamar. And I think that came across in our presentations as well, in kind of those challenges that really come with that power and example. And I think there's some really great practice happening from our team at the other side. But I want to come to you, Sharif, as someone who has been a peer worker, but also now a nurse. Woo, I think you've just finished. How do you manage that conflict and those identities that kind of come into it? I think, especially given what Tamar's just discussed.
Thank you. And thank you for everybody in the room for allowing me to have that at the beginning. But I got to say, it's a bit like asking, how do you leave yourself behind when you go into work? I don't think I can leave. So my PTSD, my diagnosis, my mental health is part of who I am. It's part of what my kids know. It's part of what my mum now knows. So I can't leave that and then go into clinical practice without the peer lived experience. And I think it's been one of the most challenging things that I've ever done in terms of switching careers. I mentioned a security manager before, but going into the NHS and then learning how to sort of use my lived experience has been very challenging. And it's still challenging because once we've finished, we haven't finished, the work is still going on. And I think the more I learn about peer support, being at the conference we had and the grassroots and the history of it, the more I get to understand that it is not something new. It's always been there like the fire, but the organizations and the system sort of don't want that peer lived experience, or people use their lived experience in practice. So I think that's a great shame actually, because I've been inspired along my journey by great nurses, psychiatrists, doctors, and I just think it's a shame that whenever I'd say, oh, you know, last night I felt a bit off key, or I'm going through it right now, they sort of just say, well, should he be here? And then it always becomes a conflict for me, and I haven't been able to share that with my other mental health nursing students. So that gives me a worry for the future of nursing, because we're still, as nurses, not being encouraged to use that lived experience, but it's very hard for me to leave it behind. And to be honest, I don't think I can ever leave it behind, because I never thought I'd be invited here. And it just goes to show you the authenticity that comes with peer support is really important and special. So
Thank you, and thank you for sharing that. So I work in a mental health nursing team. I'm not a nurse, so do not ask me to help in any way or shape or form. But what could nursing kind of teaching do you think? Do you think there's anything that could be done from kind of universities teaching?
I don't think it's nursing's responsibility. I think it's a responsibility for all of us, for society, to just be the authentic selves and be able to say I felt suicidal, or I felt like harming myself 2 hours ago. Yeah. So I don't think it's, even though I've become a nurse and I see that in nursing, the reason that I became a nurse is because out of all the healthcare professionals that I spent most of my time with as an inpatient, it was nurses that had an impact on me. So I felt like, how would I make an impact? And I think as a nurse, my personal experience is how I make a difference is I call it when I see it, or with somebody that I'm working with, if I can say, hey, I've also felt suicidal, I've been sectioned, I've been in, and that often, I've never had a backlash from it. I'm not saying I never will, but every time I've shared that with somebody, it's helped me get through it, because as a lived experience practitioner, I always have it in the back of my mind that I could be unwell at any point. So I think nurses would do well to just be themselves, be authentic. And I do think there are nurses and other professionals that do it.
Thank you. I have to ask the nurse question so that my manager's happy. Julie, we haven't heard from you yet. I wonder, do you have a response to anything that's been mentioned, or are you happy for me to ask another question?
To answer. I think it's, as somebody who I was admitted prior to going into nursing, and have used services on and off throughout my life. And as a nurse, and then as a nurse leader, I was associate professor of nursing and a nurse manager, and have written quite a lot around using lived experience. I think it is absolutely true that we need to be authentic, but that we do need to give practitioners information and skills about how to draw on their lived experience in their practice. As somebody who finds themselves sitting opposite to practitioners quite often, they feel because they know my background, they will say, you know, oh, don't worry about that medication, I take twice as much as you. Or they'll say things like CPN coming to my house will say, so pleased to see you're out of bed. Nobody else this morning, who I've seen this morning, has been able to get up. And when I'm down, I can't get out of bed. There are these are really damaging ways of using a lived experience, which immediately make you feel very dismissed and as if you can't possibly warrant the support. So I do believe that we should all be drawing on our life and lived experience in our practice. That doesn't always mean saying, I have the same diagnosis as you. It means knowing what it feels like to sit opposite somebody who is dismissive, who doesn't validate you, who doesn't listen. So it's not just hearing that they too have used the service, but actually it changes the way we work. It changes the way we relate to people. We relate to them as a fellow human being, and we're working together to find a way through. That's automatic if we've also used services. I suppose the other thing is that I just feel, I think I do feel uncomfortable with the idea that, of course, I am somebody who's used services and have worked in services and now have moved out of services. So we've taken IMROC out to become a registered charity so that we are freer. We want to be free to be able to critique and comment and take some decisions about really trying to offer alternatives to the way in which mainstream services are going. But although everybody in IMROC has used services, as we've become more successful, as we've written more, as we've gained more funding, then we lose our status as grassroots practitioners. We lose our status as people who have lived experience, and we start to be seen as on the other side. And yet we have now 60 trainers, all of whom are people with their own lived experience. They're not people with professional training. They're people who have come in. They have phenomenal expertise. There are amongst them all kinds of teachers and architects and graphic designers and footballers, Tai Chi experts. But IMROC isn't seen as a grassroots organization because now we pay people very well. They're paid at the same rate as professionals. They are there really supported to bring that voice. And I think we mustn't forget that, yes, we do apply for funding, and we get funding because we've come together in a successful way. And so I know is that I'm on the Disability Rights Commission Research Board, and £6 million a year goes to user-led organisations, LEROs, lived experience research and practice organisations. That £6 million is all decisions are made by an entirely lived experience audience. So there's something about how we use our language. So I would say it's just a difficulty, isn't it, of saying they know money goes to lived experience, when in fact then people aren't always saying we're a lived experience-led organisation. They may well be like IMROC, we're a lived experience-led organisation, but we don't talk about ourselves in that way. So I guess this language is important.
If anyone is very interested in the topic of professionalization within lived experience, there's an amazing co-production session in the afternoon that you should definitely come to that's in this room.
Could respond to
Yeah.
that. Yeah. Just to respond to that, it's a good question. It's something that or a good point to raise. It's something that is debated a lot within the MADS community. It's something that I've actually brought a few of these along. It's a zine that's written by Lucy Costa and Lisa Malta, who are both lived experience academics. You'll notice that I've spoken about lived experience academics and also, I'm a lived experience consultant. I expect to be paid just at the same rate as anybody else that I'm working with, because I've worked hard to get my degree and my master's and, the professional expertise that I have from, other disciplines that I've worked within. However, one of the things that I do within the work, the consultancy that I provide, is that as essential, what I do is I work from a lived experience lens. So that is the difference. And it's actually having that link to the grassroots MADS community and the connection, and it's using the insight from the lived experience. It's kind of the idea of bridging work. So it's the lens that you work from. In research, we talk about things like constructionist lens and positivist lens. You can go into it sort of very theoretically, but what I would say is that lived experience practitioners work from a specific lens. And once you're working within an organisation where job titles and job descriptions are basically the same as you would expect within any other organisation. So the way that Mind would work, for instance, and that, for instance, I'll give you an example of within the NHS, some peer support workers are paid at band 2 and band 3, and there's, you know, the idea of sort of power and decision making, etc. There's a lot to be spoken of about it, but what I would say is that in particular, what Peter Beresford, Diana Rose and Sarah Carr, the points that they were making was that actual lived experience led organisations that have those links to the community and that are working sort of from that experiential lens, so that have kept that, do not get that funding. And that's within the paper. It's something that I can probably share on Twitter, for instance. Also, I've got a load of copies of these zines. They're amazing. They're to a bit of history of lived experience labour and go right back to the 1890s and the idea of where it comes from. So, for instance, you know, free labour. Sometimes people with sorry, yeah, I try and be really quick. People with lived experience in asylums have often been used for free labour, and you think about now, often service users are used for free labour when it comes to improving services. And it just goes through a history of the type of labour that we use, and also on later on, it goes on to the really difficult questions about payments and actually accountability and some of the issues that Julie's mentioned as well. So it's an incredible zine, takes really difficult questions, puts them really simply. You can have some, I'll shove them on the table after.
Thank you, Tamar. I have a few more questions, but I want to put it out to the panel. So Roving Mike Karen, do your work. If you can just let us know who you want to answer, that'd be great.
Hello, I'm June Brown, King's College London. I've been very impressed by the presentations this morning in terms of the quality of the presentations, the breadth of the content. I'm sitting here, I kind of think I'm not to do with peer support, but I do talk to a lot of people who use the services. And I suppose I'm struck by the breadth of work that you might be trying to do. So it feels like you're talking about grassroots, you're talking about lived experience, you're talking about training, supervision, you're also talking about effectiveness of peer support. And I suppose it feels like a big thing to try and actually cover. For me, it feels like a really important area to work in, given the shortage of resources that we have to support people with mental health problems. And it feels like this is the kind of start of a journey in a lot of ways, rather than, you know, you can say, yes, this is really respected and this is the direction that we know where we're going to go. I suppose my question is maybe for Ruth rather than for anybody on the panel, but let me ask the question. It feels like what peer support workers are trying to do is really important. I suppose my question is just to do with, if we're trying to say peer support work is important, and we're also trying to say it's effective, is there work to actually say, what is there a kind of ideal length of time for peer support workers to be working with people? Because it often feels like you're crossing boundaries. You're not saying, oh yes, this patient is in the inpatient side, therefore that's the end when they're discharged. You're saying you're going to follow them up, you're going to offer them culturally appropriate work. So I guess my question is something about the length of time that
Can I
can
answer
be
you?
offered.
I'll answer you because I think it's really important to know that peer support refers to that mutual reciprocal relationship between two people. And because by definition, we're not relying on professional expertise, it's something which is emancipating, it is empowering. We learn ourselves that we are able to find our own solutions, and it can really help to come together with someone else who shares those challenges. The nature, the best type of support, the peer support for any individual in any situation will vary hugely. And one of the real challenges is when we start to get together and try and make it fit a very, very clear definition. So what there is agreement about is what are the values that underpin peer support. And it's through those values that we recognize it. This is peer support. Now, research or randomized control trials need to take place on does peer support work, if it is offered for this length of time in this setting by people trained in this way. It's very difficult to say, does peer support work, when sometimes it will be a long-term friendship in a self-help group within a community. But the great thing is there is agreement around what are the values underpinning it. And from my perspective, there's a real disappointment in the research. So the latest trial, the NIHR trial, looking at peer support in an acute inpatient unit, peer support workers helping people as they transitioned into the community. The average length of contact was 2 hours. I would say that doesn't qualify as peer support, and it's not surprising it wasn't effective. So you are right. We need to be clear what we're talking about. One of the problems Ruth will have found is that people are called consumer aides, they're called peer support, they're called specialists, everything. As time, we're at the beginning of a journey. As time goes on, we'll be able to refine. I'm disappointed that Ruth's research hasn't found more, that an evidence base which actually sits more comfortably alongside what we hear on a daily basis from people who are receiving peer support. There's a real problem with the measures she's saying, but the other thing is that there's a real difficulty in saying this does improve recovery whilst not improving sense of equality of life and social networks. Recovery is a very, very broad measure around living life the way we want to lead, which would include quality of life. So we could debate Ruth's paper for a long while.
How long would you guys like to respond to that? You don't have to.
I would say I would really pick up on your point that really and truly it's individualized. What works for one person wouldn't necessarily work for another, because everyone's life and everyone's journey is completely different. And mental health generally is not a linear kind of thing. It goes up and down, and that's much like anyone else's life. So I think if we work in a linear form, it's not going to work. Whereas if we work in something that is individualized and looks at somebody's holistic kind of life, then it kind of will be changing depends on what's going on. So somebody could be really kind of recovered or well at one point, and something may happen and they may need that support again. And it is not really something that you could say, okay, we're going to work in this way and then say, okay, bye. I think it's something that it has to look at based on what's going on, and it, whether that means someone has to re-refer or somebody just stays on the books so that if they need that support, they can still have it. I think it's really important because a lot of people don't have that support at home and they're looking for the support from somebody who understands their journey. And I think if we don't provide that, then who will?
Yeah, I just respond to that because I've been working on the peer the peer work has covered the peer research has covered quite a few different strands, and within the League group, one of the things that we've raised is that there are real issues with the research questions and the funding. So right from the get-go, we get asked to do something from a funder and we have constraints over what we ask and how we ask it. And it's really frustrating, and especially when it's been asked to do within a specific time frame. And we all know that co-production should, if it's done properly, it should take, it takes a long time. And it's something that we're always raising. I mean, within the lived experience working group, one of the things that we do is critique that within the lived experience commentaries. We also try to, within the constraints that we have, push as hard as we can to work within what we've got. And one of the other things that we find is that because of the ambiguity of the way that lived experience working is currently, is that you ask questions around recovery or co-production. Language is so variable at the moment, it means nothing. So when you put together a questionnaire, that, you know, whatever you're doing, when you're asking questions, basically they're interpreted by people in different ways, and it's very frustrating. It doesn't matter how skilled you are as a interviewer. It's really, really difficult. And this is one of the reasons why why this type of research needs to be led by lived experience workers and linked to the MAD knowledge that we have. Even if it isn't led, it needs to be kind of co-produced. And one of the things we say within the PRU is that we're trying to work towards co-production. We would say that we don't co-produce, even though it's one of the closest things I've come to co-production. I won't go into that because
that's what this afternoon is about. Thank you, Tamar.
Yeah.
And I think that just shows from a lot of what we've talked about, the complexity of doing work in peer support.
I was just thinking, sorry, is it June? You was asking how long it take. I was just thinking as I sat here and listening to everybody, and I think there's something that I have to say about peer support, and I have to be really honest. And that is that peer support, as amazing as it is, it's not going to work for everybody. That has to be said, and I'm saying that because I'm still a practicing peer support worker. One of the biggest pressures is a system that wants you to constantly be successful because you've got lived experience. So we have to acknowledge that. And as peer support workers, we're not in charge of it's going to work. It might not work with that individual. I just had to say that because I felt like that was such an important thing to say.
Thank you. We are 4 minutes until lunch. So last question, Raza.
No, that was a really salutary reminder. What I would also say is that the mainstream mental health system isn't particularly successful and is very, very dysfunctional. So I think we should really sometimes give ourselves a pat on the back, because I think there's so much more pressure on us. When I say us, I mean people with lived experience, researchers, to kind of prove ourselves with a very tiny amount of that funding cake, with very little control, and with such high expectations for us to succeed and demonstrate the evidence base, where the mainstream system is not held to account in nearly the same stringency. That's what I wanted to say.
Nora, you have 1 minute. Because lunch is getting served downstairs.
It's just a very quick question. Hi, I'm Nora, and I used to work for the Policy Research Unit. And I was just wondering if you have any knowledge or any thoughts about peer support work with people whose first language is in English, or with ethnic minorities, if you know about any good programs.
Just to let you know that we are working with refugee hotels with various organizations. They are translating peer training into 10 languages, and it's around ensuring that all of that support that's offered to so many people who are so traumatized and so distressed is offered. It's not the full peer support training, but it's 4 days of just ensuring that it's safe, appropriate, and supportive. But it's in different languages, so you can get in touch with IMROC and we'll just let you know.
And do you guys want to have any?
Yeah, I think I'll try and be quick. I think that this kind of brings us back around to the point of kind of culturally appropriate support. Again, we've talked about individualized care all day. I think that having your culture be at the center of your care plan, of your discharge, of your sectioning, whatever it is in terms of what part of the system that you're going through. I think that it's very important that all of that is familiarized and is taken into consideration.
I mean, I'm going to say the same thing. So that's really helpful. But then I think also as well, I think it shouldn't only be the responsibilities of the different services. And I think there needs to be a whole change of the general mental health system, which these things are actually seen. And it's not only the, acute services that we are seeing, we can see these things to be done in the communities, because I think the services, like you said, are not held to account in the same way that other services are, the third party sectors. They need to be, for them to be kind of seen to be not working for the people that they're supposed to be serving. So I think it's important that these changes are made generally.
I think sorry, I know we're pressed for time, but one really important thing for me is that it's important to mention that practitioners shouldn't have to be an expert in every single culture. It doesn't mean because we do culturally appropriate care, I know about every single individualized tribe in Africa, or every in neighborhood in the Caribbean, right? It just means that I'm open to being culturally curious, to being open about who I am and what I bring to my role. So having some level of cultural humility with the work that I do. And also being open to allowing individuals to kind of bring their full selves in turn.
Final word to Sheree.
Just quickly, and I'm only saying this because I speak multiple languages and I came here as a refugee. If you're asking for how to help that individual, it's in their communities, probably in mosques, churches, places where the stigma is really thick and difficult to reach. But that's where I would encourage you to go, because you would find other people there who have similar immigration problems.
Fantastic. I know we could talk about this all day, and I genuinely have so many questions I didn't get to ask, but it is lunchtime. So if you want to make your way downstairs, just to the main area where we were this morning, and then if you come back up here at 2 o'clock, 2:15, someone will tell us. Then there is a co-production session that is interactive, and we'll be able to chat about some of these issues. But I just want to say thank you to everyone on the panel, everyone that presented, and everyone who's been involved. Is everyone happy to have a picture? Yeah, go for it.